All right. Thank you, everybody, for joining us today. I am going to start the video here and we will get started. All right. Well, I'd like to welcome you to the 2021 Virtual Series Forum on Aging in Rural Oregon. Rather than our traditional in-person event this year, the Oregon Office of Rural Health is hosting a series of virtual forum sessions the third Thursday of each month from 2 p.m. to 3 p.m. We do plan to be back in person in Seaside in 2022. I'd like to thank you for joining us today and give a big thank you to our partners, Central Oregon Health Council, the Older Adult Behavioral Health Initiative, and GOBI. Carey, can you advance the slide, please? I'd like to let you know that our speakers have no conflicts to disclose. And next slide, please. And before we get started, I'll orient you to this virtual platform. The audio has been muted and the video is turned off for all attendees. Select the ellipses on the bottom right, far right, to populate the chat and the QA features to your right. We ask that you please ask session questions using the Q&A and use the chat function for everything else, including any technical difficulties you experience. The slides and recordings for this presentation will be posted shortly after the session on ORH's website at the link on the slide. And we'll send you an email as well to let you know when the recording is available. Additionally, if you'd like CEU for this session, please complete the survey at the end of the session, and I will post a link to the survey toward the end of the session. I'll also send an email in the next day or two, which will include, again, the link to access the slides and recording, as well as the session evaluation link. And with that, I am pleased to introduce our speakers today. Dr. Kylan Mattias de Vries, PhD, holds an appointment as professor in gender, sexuality, and women's studies and sociology and anthropology programs at Southern Oregon University. His scholarly interests include inequalities, intersectionality, transgender studies, critical race studies, and social psychology. Also, we have Dr. Carey Jean Sojka, PhD. She is an assistant professor of gender, sexuality, and women's studies at Southern Oregon University, whose research and teaching interests include transgender studies, embodiment, gender, sexuality, race, disability, and fat studies. Dr. Sojka also conducts community trainings on transgender, lesbian, gay, bisexual, and queer issues through the Trans and Queer Training Program. And with that, I will let you take it away, Kylan and Carey. Carey, I believe you may be on mute.
Of course. Hi, everybody. I'm Carey Jean Sojka. I use she and they pronouns, and my co-presenter is Kylan.
Hello, and I use he or they pronouns.
Fantastic. We are going to cover a variety of things today. We're going to spend the most time on our first bullet point here, thinking about the challenges that trans people, including both binary and non-binary trans folks, face when accessing healthcare in rural Oregon. We'll also spend a little time addressing the ways participants in our research study were responding to and navigating those barriers that they were experiencing. We'll do a little bit of like 101 introductory stuff on how to advocate with and care for trans communities, especially in rural spaces. And finally, we'll share a little bit about some trans educational resources that we provide through our university.
We want to briefly touch on our research and where our data is coming from. Next slide. So this was an ethnographic project which entailed collecting data from a number of sources. We participated in roughly 55 hours of in-person community peer groups and over 100 hours observing online peer groups. And we also conducted 58 in-depth interviews. All the names in our presentation are pseudonyms picked by the participants. Next slide, thank you. We conducted this research in rural southwestern Oregon and rural northwestern California in the counties with a movement to create a state of Jefferson. So for those of you who don't know, this movement began prior to World War II and has been revitalized in recent years. And we do not mean to suggest that this movement has a likely chance of forming a new state, but rather that it reflects the shared conservative and libertarian ideologies of this region. So our data collection focused on Curry, Douglas, Klamath, Jackson, and Josephine counties in Southern Oregon, and Del Norte, Humboldt, and Siskiyou counties in Northern California.
So we want to chat with you today. Again, most of what we hope to do is tell you a little bit about our findings, what we found when we talked to trans people about their experiences. Although our study overarchingly was not specifically about health, it was about just general rural trans experiences. What we're sharing with you today is what we found in terms of people's experiences with seeking and accessing healthcare. So when we did this, our analysis kind of showed us that there were three main challenges that our participants were telling us over and over that they were experiencing. The first challenge is that they were experiencing barriers to even establishing healthcare. This is a systemic and structural problem that they were having, and it was happening before they even got in the door. The sort of second big challenge that our participants were finding was that their providers were lacking sometimes very basic knowledge about trans experience or trans people. And that was creating problems and challenges for them as well. The third area that we found was that folks in our study were experiencing discrimination, both explicit and implicit forms of discrimination. And then, so we want to talk to you about those three sort of challenges that people were facing and what that dynamic looks like, especially in our area of rural Oregon. And then we want to talk a little bit about the responses that the people in our study had, how they were responding to and navigating these challenges that they were experiencing. So we'll start by talking about challenge number one. These were our barriers to establishing care. A lot of our participants mentioned that their first problem was difficulty even finding providers in the first place. They had trouble finding providers who either had experience working with trans people, had some knowledge about trans issues, or at a minimum were at least trans friendly and not hostile towards trans people. Gray was one of our participants who noted that I have no idea how I would even find trans affirming doctors, the same with therapists. This was echoed by many of our participants. They didn't even know how to begin looking for trans affirming providers. Unlike more urban centers where there might be LGBTQ+ organizations or even trans specific organizations that house and update information about providers, that doesn't really exist in these rural areas. In fact, during the interviews, many participants asked us if we had recommendations for trans affirming providers or if other participants had made recommendations. Some participants had also addressed this by finding other trans folks online and creating informal networks to recommend or often to warn against specific providers. However, this approach still ran into some challenges. Not all the trans affirming providers recommended through these informal networks were even covered by participants' insurance. We observed many exchanges on social media where providers were recommended in a post, followed by comments that the provider or agency was not covered by insurance, and then pleas for any names that were covered under a specific insurance plan in a specific region. In addition to insurance barriers with providers, other participants also ran into issues with specific procedures or prescriptions. For instance, April, one of our participants, noted that every time I have to get my hormones, it doesn't show up on their list of things that you're supposed to have as medications. And then with the surgeries and everything, and just encountering different levels of bureaucrats who are unsure about whether it's covered, it's like, well, I've already verified that it was covered. Well, I don't know that it's covered, was the response. You go through this whole thing and you're in this constant state of distress, wondering how this is going to play out. So for April, every time that she had to go in and get her hormones refilled, she had this thing that kept happening over and over. It was this constant barrier in terms of access, even though she technically had insurance access, she technically had access to these medications and procedures. The constant stress of navigating these access and insurance issues created a significant barrier for many of our participants in establishing quality care. A third issue under these barriers of establishing care was that a lot of our participants found that there was just a lack of providers. There weren't as many providers as they would want. Once a trans person would get the name of a trans affirming provider that is also covered by their insurance, or if they're able to pay out of pocket, which was not very often, they would meet another barrier to establishing care. Anthony noted that, quote, I called all 43 on the list of mental health care providers. Of that, 9 said that they felt it would be within their realm to write a letter, meaning a letter for surgeries, and 3 of them were taking patients. And so we have this way in which even, this broad list of providers that are supposedly there, many of them are not willing or able to work with trans people for the sort of trans care they might need. And then, very few of them are actually even available to take clients or patients at the time. Well, this was a common experience for behavioral health. This is also a common experience for medical providers as well. Kitty said that one of the problems with regard to healthcare in the rural area is that there is exactly 1 endocrinologist that works with trans people, and there is no access to gender reassignment surgery. So for some procedures or some medical care that trans people may want, there was literally no one in the area who could provide that care. Other times there may be only 1 person that could provide that care. While these quotes are highlighting finding care from providers, it's specific to trans-related healthcare, like hormones or surgeries. Other participants shared many challenges in finding providers for non-trans related care, where they just wanted a provider to be minimally trans-friendly and competent. They mentioned things like dental appointments or eye care or physical therapy, going to the emergency room or urgent care for a broken bone, things like that. In other words, these were situations where being trans really didn't have an effect on the health concern, but where they had still been turned away from care because they were trans, which then limited the number of providers in the area for them. Furthermore, with the limited number of trans-affirming providers, the wait times are very long in these rural areas. Marisol explained that, for me, the consultation for one operation isn't for 2 years, and then the consultation for another one isn't until the following. And those are just the consultations. Then having to wait another 2 to 3 years while being on hair removal, then setting up the actual surgery. Participants in these rural areas, often complicated by a lack of providers and insurance and access challenges, often had extremely long waits for this very important and necessary care. Finally, in barriers to establishing care, this is not final, this is second to last. Another one was that many patients had to re-establish care multiple times over even a few years. So for instance, Autumn noted that a lot of our doctors and any healthcare providers we get here, and this is in some of the more rural areas, are traveling. That's how we get a good chunk of our care, is people who are not committed to the community. There's little accountability for the knowledge base they're bringing, and they could be gone by the next time you come back. This often meant that trans people had to either come out multiple times to new providers or choose not to come out to their providers and risk the potential of not getting the full care that they might need. So even within the same practice, this reestablishing is having to happen over and over. The uncertainty of what information might be passed on to a new provider and how that would be perceived, especially in relation to their trans identity, would add to the barrier of establishing good quality regular care. Sorry, and the last one in this section of the barriers to even establishing care in the first place were that many participants felt they had to travel to medical hubs to receive care. For Southern Oregon, Medford is that medical hub for a lot of people. And participants from outside that area would travel very long distances to get there. All the participants outside these medical hubs would share their difficulties in first finding providers and second commuting to those providers. Some would travel to Portland and or to San Francisco, but others did find rural providers in their areas, but often this still meant a full day to get to that provider and to return home. As Forrest noted, I don't really see my doctor often. It's been tough in the sense that I have to drive 3 hours just to get hormones. It's a little bit ridiculous, but okay, I still have access. Most surgical care entailed traveling to either Portland or San Francisco for our participants, and the majority of trans participants shared a frustration with having to travel distances to get places. Especially for things like surgical care, it often entailed multiple visits to those locations and the arrangement of a place to stay and recuperate, all with significant costs associated with them, and time off work, which was often very limiting for many of our participants who were working class.
So the second challenge for trans people when accessing healthcare in rural Oregon was in relation to the lack of provider knowledge. Next slide. Next slide. Thanks. A number of participants perceived that they knew more about trans-related healthcare than their providers. So Gray shared, I can totally go see a therapist, but I don't trust anyone. I don't trust anyone to have any idea of what I'm talking about in terms of my gender or how that relates to issues I have with my family or my community or my partner. I don't. I just know automatically I'm going to know more than my therapist or my doctors. This was concerning because while they might know more about some trans-related practices or health needs, the majority weren't educated or working in medical fields. Next slide. Next slide. Yeah, thanks. The trans narrative refers to the idea that trans people are moving along a binary of male to female or female to male. The expectation that they have severe body dysphoria is part of that, and that they express strong alignment and gender expression of, quote, the opposite gender with which they were assigned at birth. This is the experience of some trans folks. However, there are trans folks who have very different experiences and still want to be recognized as the gender they identify with, without having to play into this expected trans narrative. In particular, we found that non-binary identified participants shared the challenges of not being viewed as either authentic about their gender identity or not having their pronouns acknowledged. This was particularly true if their clothing appeared to align with what the provider perceived as their gender. So Jay noted, the first therapist I met with, I think they really wanted me to go on the trans narrative, like starting testosterone. Do this, do that, do that. I think one time I came in wearing a skirt because it was hot. I was like, I can get away with wearing a skirt. There's nothing wrong with it. Clothing does not equal gender. I think that shut the door for me on that. In this case, as long as Jay wore masculine attire, in their therapist's eyes, they fit this trans narrative. But as soon as Jay wore something feminine, the therapist perceived Jay to be inauthentically trans, which created barriers for the types of care that Jay needed. Next slide. Similar to other research, a number of participants did not trust their providers with knowledge of the trans status. In other words, they were not out to their providers as trans and experienced a high level of fear in coming out to their providers. Marisol explained how she experienced most interactions with providers. I'm dressed very femininely. Underneath, there are some parts that people wouldn't perceive to be feminine. So it's going to be an awkward situation. I know of their training and I don't know their training and I don't know their level of competency with transness and that kind of thing. It's never a comfortable position to be in. It's more like I have to put myself through this in order to get what I need. I just have to, for lack of a better word, suck it up. That's not something that should be the case. Or past experiences with providers significantly shaped trans people's expectations towards new providers and the high levels of stress they experienced in preparing to see a provider. In addition, particularly non-binary trans people felt, as one participant stated, quote, very suspicious when people say that they're cool, because sometimes they aren't. Next slide.
So it's significant to us that we wanted to focus on these barriers to establishing care and on this lack of provider knowledge or lack of trust in providers as two really significant things. Trans people in rural areas are absolutely experiencing discrimination directly from their healthcare providers, from healthcare systems, from many people within those systems, right? That this is absolutely happening. However, it is not the only way in which trans people are experiencing challenges related to their health. And unfortunately, sometimes we only focus on discrimination as if focusing just on sort of interpersonal discrimination that trans people face will solve all the problems. And it absolutely won't, right? They will not solve all those problems with, insurance challenges. It won't solve the problems of transitory providers. It will not solve the problems of having less than fully prepared providers to work with trans clients and trans patients. So we want to talk about discrimination, but we want to make sure that it's couched within that sort of broader understanding that this is one of three main areas that our participants were telling us about that created these challenges for them. So explicit discrimination was absolutely a big part of many of these participants' experiences. Most trans people in our study would share a story of a provider who had refused to work with them. As Forrest explained, there's quite a few doctors in the area that are openly very transphobic and unwilling to work with someone who is seeking hormone replacement therapy. Most of our participants had a recognition that this was the reality, that there is a lot of providers who are explicitly, overtly discriminatory against trans people. Some of our participants would share stories about like sort of active overt hate in terms of when they were seeking healthcare. People saying things that, you might be surprised that they're saying in healthcare clinics, and yet it's happening in these rural spaces. But even when it's not that sort of like overt hate language that's happening, there's still this sort of explicit discrimination in terms of refusal to work with people. Forrest is talking here about the sort of failure of people to work with trans folks who are seeking specifically gender affirming care in the sense of hormones and or surgeries. But there were a lot of trans people who also experienced this explicit discrimination and or refusal of providers to treat them based on, just broader stuff, right? Just based on them being trans. There's a really interesting study based on this idea of the trans broken arm, which is really telling us about the fact that, a trans broken arm is not treated any differently than anyone else's broken arm, but many providers act as if it's different and will refuse to treat the trans person, even when it's something that they would commonly treat. And a number of our participants experienced that type of discrimination in our study. In addition to the sort of explicit overt discrimination that people experience, misgendering was a form of that. Sometimes misgendering can be a sort of explicit discrimination when done intentionally. It can also be a form of a microaggression. If you're not familiar, microaggressions are these small interpersonal interactions that invalidate and or put down a person's experience. Sometimes they are explicit, sometimes they are consciously done, sometimes these microaggressions are unconsciously done. And the important thing that we want to remember when we're thinking about microaggressions is that they are still structural, even though they're happening on an interpersonal level. So they're still happening broadly. They add up over time. So an individual microaggression might not be that big of a deal, potentially, but people are experiencing microaggressions continuously throughout their life, and they do add up and can actually create like significant trauma and harm in a person's life. And misgendering is one of those forms of microaggressions, right? So this idea of not gendering someone correctly. Sometimes participants would experience this misgendering with initial interactions. So even, for instance, with the sort of front-end staff, right? The people that they're interacting with as soon as they go into a healthcare clinic or an office of some type, people would say, "Good morning, ladies," or "Good morning, ma'am," or "Good morning, sir." That sort of immediate gendering that's happening in that moment. And that's actually, very harmful to a lot of trans people to have that sort of automatic gendering that does not align with their actual gender. Second, a lot of our participants would experience medical providers letting them know that, you know, they were misgendering them. So for instance, Lee here said, I was getting my blood drawn and I fainted. And then I just remember fainting and hearing the lab guys misgender me. I was like, I'm supposed to be safe here. A lot of our participants experience this misgendering sometimes as this, you know, sort of, it's a failure to care. Like it's a failure to provide a safe space for them. It's a very harmful act. And then third, a lot of our participants would experience continued misgendering of a trans person by the provider. This misgendering would contribute to significant barriers. Sometimes a provider would actually correctly gender that person in interaction, and the trans person would only find out later when they were, for instance, reading medical notes, like reading their chart notes and stuff like that, that their provider was misgendering in chart notes, even though they seem to be affirming their gender in interaction. And these are all creating significant barriers, significant challenges for trans folks in trusting their providers, in feeling like their providers are a safe place to turn to, and generally just being able to access care. And we don't, again, we're talking about discrimination. This is a really big and broad area. So we have that sort of interpersonal discrimination that's happening, whether that's that sort of explicit stuff that's going on, whether that is misgendering, which can potentially be more subtle. But there's also a variety of other types of structural discrimination that trans people are facing. So for instance, several of the participants in our study were talking about getting hysterectomies through a provider in a women's clinic. Since this was one of the only providers, or maybe the only provider covered by their insurance in the area. Peter, for instance, shared his experience as a meeting with the provider for his consultation. He said, I had to go to a women's clinic for my hysterectomy. I was so nervous because I walked in and all the ladies just kind of like, they could tell I don't belong and everyone's giving me weird looks. I'm just sitting there like, I don't want to be here either, and I'm so nervous. But then the doctor was really nice. She just knew my pronouns. So even in these moments where you have, like, in this case, a specific provider who's doing really great and not misgendering and not doing this sort of other explicit discrimination stuff, there's still this structural piece that can be really limiting and create barriers for trans people. In this case, being someone who does not look like a woman seeking care at a women's clinic is creating really significant anxiety and barriers even just getting in the door. In terms of that, the sort of structural discrimination looked like physical spaces. Sometimes it looked like a lack of accessible bathrooms, right? So a lack of bathrooms that were accessible kind of regardless of gender, especially for non-binary folks. Sometimes that structural discrimination included a variety of problems with the sort of systems that medical clinics had. So for instance, barriers with their like intake forms, right? Like how they do gender on intake forms, or how they ask about partners, or how they, you know, like all of those sorts of things that can have these gendered consequences and impacts. All of these different pieces were aspects of structural discrimination that many of our trans participants were facing.
Okay, so we've talked a little bit about some of the challenges that participants in our study experienced. So let's talk about how they responded to those challenges. Next slide. Most startling was the extent of trans participants avoiding any type of healthcare. The US Transgender survey that was conducted in 2015, so it's a little bit older, found that 23% of trans respondents postponed necessary medical care. Although our sample size is, of course, much smaller, we found an even higher number of participants avoiding and postponing care. And it was even higher for non-binary trans people. So as Switch explained, my physical therapy office I haven't been back to for 2 months because every time I go in, I argue with my physical therapist about my pronouns. It's like because I don't have a higher income and I can't just travel to another town or pick a different therapy office or talk to my insurance and be like, do you cover anything else? I don't have those options. So it's like I don't go, or I go and I suffer. And I think what's interesting about this quote is Switch is suffering by not going to their physical therapy office, and yet they deemed going to their therapy office was more painful. So discrimination causes enough trauma for trans people to avoid this much needed care. Next slide. Several participants who had undergone medical transition did not want others to know about their trans history. They wanted others to treat them as the gender they identified with. And in this case, Brandon wanted others to treat him as the man he is. So he stated, out of 8 PCPs over the years, about 3 of those I've shared being transgender with. One of them was a very bad experience. So I can speak about bad medical experiences here in this county. That's made me pretty gun shy about sharing it. Because of his rural location, Brandon had to change primary care providers more often than he would have liked. And this was further complicated because of changing insurance coverage. As an older man in his 50s, he was particularly concerned about an emergency situation arising, since his body did not completely align with gender expectations. He also did not have a partner, and most of his friends in that county did not know he was trans. In other words, he had no one who could advocate for him in case of an emergency. Brandon, like several participants, feared that if they came out to their medical providers, this news would also be leaked to other individuals in their community, thus affecting how people would treat them. And I want to add here, we found that the participants that we interviewed that were over the age of 55 expressed concern about being out as trans in terms of their age. So thinking about going into care facilities or needing specific types of care around, some of them mentioned like dementia. So thinking about what happens then to these individuals when they can no longer care for themselves and they don't have a partner or friends who can provide the much needed support that they need. So several non-binary participants also shared a reluctance to tell providers they were non-binary. Grace shared, I have yet to come out to my doctors because I'm not exactly sure how this will go. Which is, I think, is actually something I need to get braver on, because I feel like there's actual real things that I want to talk about in the healthcare. And that I feel like having to come out to my doctor is preventing me from actually knowing that knowledge that could be really useful to me. So this not sharing of gender identity contributed to their avoidance of healthcare. Next slide. A final way that trans people responded to these barriers was to take a more empowered role to educate their providers. And this, of course, required that that provider be willing to learn. So April shared, my doctor, they were not informed of WPATH, and that is the World Professional Association for Transgender Health. They had heard of the older Harry Benjamin standards from the late 70s, and they were operating off of that. At my place of work, I've gone through a WPATH training on the standards of care that prevail now, worldwide, for trans patients. I was in that situation of educating them. I was like, okay, turns out things have changed. We have different standards. Here they are, and I'm going to start hormone therapy. April was one of the few participants who worked in the healthcare field and could draw on knowledge coming out of that field. Every participant, every single one, shared a story of needing to provide some education to a provider. And this role was often stated simply as, quote, the reality of the situation.
So we want to talk a little bit about advocating with and caring for trans patients, either one-on-one or whether this is within your systems, because this is a really important piece that I think a lot of people want to know more about. So where we're going to start actually is with sharing with you not even just our ideas in terms of our sort of academic knowledge, but what our participants were saying. There were 3 general areas that our participants were suggesting that providers specifically what they could do to make things a little bit better for trans folks. And the first is to basically just be a human being, to be compassionate. The second one was to make small changes, because small changes make a huge difference. And the third one was to really work on how you are going to help support that sort of change in structure, right? Whether that literally means the physical structures, like not having reproductive health clinics be called women's clinics, right? Or bureaucratic structures. So in terms of the first one, again, like being a good human being, Phoenix noted that it would be great if providers could maintain an open mind and be compassionate with the person because they're going through a rough time. It's not easy to transition. For a lot of our participants, it wasn't only in terms of transition-related care that they felt they needed this compassion, although it really did come up with especially trans-related care, but it happened all the time, right? Remembering that trans people are people first, that they need to be treated like people, that they might be having challenges that they're going through, and to keep all that in mind as you're providing healthcare is so important and so significant. Second, a number of our participants talked about just small changes that can make a big difference. So for instance, Ross Lynn said that introductions with pronouns probably would make me feel a lot better, just because I've never had a doctor do that before. So the simple act of saying, hi, I'm Carey, and my pronouns are she and they, would make this space so much more accessible to Roslyn. Other participants talked about small things like having signs that say all are welcome here, or having, you know, like the rainbow flags and the trans pride flags and some of those other flags that are visible in like waiting room spaces. Those sorts of small things can make a big difference for trans people in accessing care and in feeling like this is a space where they can belong, where they can be safe, and where they can actually get good affirming care. And finally, and again, this is the thing we really want to emphasize today, is that you can make those changes in both physical and bureaucratic spaces. So for instance, Aurora said, make accessible bathroom areas, right? Like make bathroom areas that work not just for men and women, but for non-binary folks too. Make bathroom areas that are accessible for people of all genders, also accessible in other ways. For instance, accessible based on, you know, disability access, accessible based on menstruation, making sure all of the bathroom spaces have a variety of accessibilities to them that trans people might need. And Aurora continued, we also need to shift responsibility to not being like, oh, trans person, you have to figure out how to navigate the system on your own. Instead, here, let's make the system more accessible to you. There are a number of medical systems throughout the country that are now employing things like trans buddy systems, where trans folks who are navigating a medical system are actually provided, you know, a person who can help them navigate that system effectively as a trans person, especially when receiving gender affirming care related to hormones and surgeries, but even sometimes more generally, right? And we know a lot of medical systems are bringing in pieces like this that are helping folks navigate that system. But it seems like it's particularly important for a lot of trans people in these rural areas because of the sort of multiplicity of barriers that they are experiencing in accessing and seeking healthcare. In addition, these are some of our tips and general tools for trans care, things that we want you to be thinking about and moving forward with. So first, and again, maybe most importantly, advocate within your organizations and systems to create structural supports for trans people accessing care. That often means changing how systems operate, right? And not just changing it on a case-by-case basis for trans people, but instead working on changing that so that everyone has better access all the time. That advocacy should absolutely be in line with your trans clients, with good research out there, right? Like you need to make sure you are doing the learning alongside this advocacy, but you need to really figure out how you're going to do that. One of the best ways to think about advocating for these structural supports for trans folks is to find other people within your organizations, within your clinics, within your systems, who also understand the importance of the need for these things, for trans care, right? If you find those people, then you're not working alone, you are working together. You can create committees if you are supported in that sort of thing within your workplace. You can, you know, create policies within your organization. Again, if you have that sort of support to be able to do that, working together can help you to do that advocacy most effectively and to make those structural changes that are so desperately needed for trans people. Second, take time to learn about things like basic 101 learning is so important. Things like appropriate language and affirming practices. Sometimes the folks I chat with can feel really overwhelmed by this because the language and affirming practices can actually change very quickly when it comes to trans communities. And that can feel really overwhelming because it feels like we're constantly trying to just keep up with what's going on. And I get that. I get that it can feel really big and overwhelming, but I also want to just say that it's so important. It's so important in preventing further traumatization to trans patients and clients. It's so important in making sure that you can be there for them, that you can affirm who they are. And you want to make sure that you are learning about these things from sources besides just your patients or clients, right? Obviously, people are experts in their own experience, and when they want to share that information with you, that's great, but don't expect them to become the experts in all trans care. Don't expect them to know all of the nuances of trans care. Don't expect them to teach you all the time. So if they want to teach you, go for it, but otherwise, make sure that you are taking that time for yourself to learn that, not just from the people who you are caring for. Some of these topics to think about are things like names and pronouns. It's so basic, and we could talk for hours about just names and pronouns. But making sure that you are using affirming names, you're using people's names that they use for themselves, that is a hugely important practice. And I know that it can be challenging when you might have systems that require legal names because of insurance purposes or because of a variety of other reasons. And especially when those legal names do not match someone's affirming name, that can be really difficult to make sure that you are doing affirming practices while also managing these bureaucratic systems. But you can do the work of that instead of putting it onto a trans person to have that sort of complexity there. With pronouns, it's both so simple and so complex. English is this weird sort of language. We have gendering built into not just the words we have for people like woman or man or all of that, but we have gendering built into the ways we refer to people when we don't use their name, right? Not all languages have this. There's a ton of languages in the world that don't have that sort of gendering that's built into the language in that way. Again, they still have gendered words within those languages, but it's not in terms of pronouns. So languages like Kiswahili and Finnish and Japanese, and there's tons of others, they don't have pronouns in the same way. And so they're not dealing with this pronoun issue in the same way we are in English, in the same way people are in other languages. So for instance, like French and Spanish, that gendering is definitely built into those languages. So learning about what that means to use pronouns and make gendered assumptions about people, things that we're taught to do from infancy in our society, right? We're taught to do that as we're learning to speak. It's this gendering thing that can lead to misgendering, which is harmful for a lot of trans folks. So although names and pronouns are, they're both complex and very simple, and they're ultimately incredibly important for affirming trans patients and clients. And it takes some time to learn about and to practice, especially things like pronouns, making sure you're using them appropriately and in an affirming way. Making sure you're taking time to learn about the complexity of identities is also hugely important. New identities are coming about every day, and it's not that they're new exactly, it's just that we're finding new words, or people are finding words that seem to fit better for them in terms of understanding their identities, right? So it's both new and not new, but that language, keeping up with it can feel really complicated. The complexity of identities is really important as well because, for instance, if we think about trans care, a lot of times people focus specifically on binary trans care. And a lot of our non-binary participants in these rural areas would actually talk quite significantly about this, how their provider might be really great at working with binary trans people because their provider understood, a sort of gender experience, that trans narrative within that binary. But when they were experiencing gender outside of that binary, that was a sort of complexity that these providers were not prepared to handle, were not prepared to encounter, were not prepared to affirm. So understanding that complexity of identities, again, from sources besides just your individual patients or clients, can be so important. Learning to avoid assumptions about people, and as well as language that can be harmful. There is so much in terms of language that can be used very well intentioned and can actually be incredibly harmful. like words that used to be used and sometimes still unfortunately are used even within medical spaces that trans people routinely have said that's actually not a good word for us. Sometimes what happens is that some parts of the trans community will start to feel that certain words are harmful because of their histories, because of a variety of reasons, and other people will still feel like those are good words for them. So as an example, the word transsexual is a word that has a lot of like controversy around it right now. There are absolutely some people who feel that that is a harmful word, and part of it is because of its history as a pathologizing word. Like it's because of its history in terms of healthcare, and trans people are feeling that that's not something that works for them in the same way anymore. However, there are still trans people who use words like that. So gaining an awareness of the sort of histories of these words, how they're being used, how they can impact people, can really help you to do trauma-informed care, to not be continuing harm against trans clients. And just a sort of side note with that, it's always best to mirror back the language someone uses for themselves. Even if you're aware that a particular word that other trans people might find that a harmful word, if that's the word that someone uses for themselves and you want to mirror that back, you want to affirm that for them. And just general gender affirming care practices, things that you can do to make sure to affirm somebody are really important, both in terms of transition related care and in terms of just, again, human related care. A third general thing, and this is part of that learning, but we wanted to name it specifically, is that it's important to regularly review up-to-date research on trans care in your field. And it's so important, but also make sure that the research that you are using is affirmed by trans scholars and activists. So it's not just coming from non-trans communities or cisgender communities, and where this is where cis people are saying that they think they know things about trans people, because there's a very big history of some really problematic research in terms of healthcare that has been done by cisgender people about trans experience and has actually been incredibly harmful to trans people. So while there's less of it today, that doesn't mean that it doesn't exist. So make sure that the work you are reviewing, the practices that you are getting, from this research are affirmed by trans people themselves, and not just by individual trans people, right? But by broader trans scholarly and activist spaces. And finally, understanding the need for regular, ongoing trans education, right? So that means not just individual education, but also collective education within your systems, within your clinics, within the places where you work. It doesn't end. There's no stopping point. There's no like place you get to where you're suddenly an expert and you can stop learning. There's no place where you get to even where you're competent and you can stop learning. It has to be a regular, ongoing practice to provide good quality trans care.
So before we get into some educational resources, I just want to re-emphasize what Carey was talking about, and that is the different experiences of sort of binary trans folks and non-binary trans folks, and then to further complicate that. So I don't want to create like another binary of non-binary and binary trans folks, but when people, however they identified, were expressing a gender that others perceived as not aligning with the gender that they identified with. And so for someone who's trans masculine, if they expressed aspects of femininity, let's say, there was sort of that inauthentic trans piece, or not being viewed as authentically trans. But then there was also sort of this questioning about any of the knowledge they shared or their own experiences that they shared. And as we sort of mentioned, even for those that identified as binary, trans-binary, bodily difference came into play. So concerns around having a body that wasn't initially visible to others, right? That didn't line up with their identity, and what were the sort of consequences of that. And then, as Carey mentioned, like forms and identification. So I'm sure many of you are aware that driver's licenses in Oregon can have an X marker, so it's M, F, or X. And then, of course, birth certificates have been changed too. So you can indicate undisclosed on a birth certificate. And so what we found with participants as well is that while they had that identification, people's forms didn't align with that. And it created this additional weight that they had to carry, or this additional challenge that they had to deal with. So let's switch and talk about in terms of ongoing trans education. So we want to share 2 resources that are both located in Southern Oregon and are available to the entire state and region. So the first is a Transgender Studies certificate, and Carey and I I have to say, are pretty proud about this. It began fall 2020, so unfortunately over the pandemic when students weren't in person, but it is the first of its kind in the nation. And the courses that are in this Transgender Studies certificate really center trans scholarship. And it deals with topics such as trans activism, trans histories, trans lives within social institutions, so including thinking about medical and behavioral health, trans literary works, and then decolonizing trans experiences, so really thinking about indigeneity. And then finally, imagining trans futures. So how do we imagine things to be different and how can we create that difference? And this certificate, the nice thing about this piece is that it's open to anyone. It doesn't have to be completed as you're doing a bachelor's. It can be a postgraduate degree. Next slide.
We also wanted to tell you about our trans and queer training program, which is the program that I run. I founded and run through SOU. This is also a fairly unique program in that it's run through a university and it's offered to the broader community. We provide trainings, workshops, and also consultation work to organizations on both trans-specific and on broader LGBTQ+ and gender and sexuality topics. And we even do some even broader like equity, diversity, and inclusion trainings. So we offer this to a lot of times organizations. We specifically partner with organizations. And a lot of times it involves understanding what the organization needs and wants out of this training, and often tailoring training specifically to that organization, to the needs of their staff, the needs of their systems, the needs that they're doing. And a majority of the training requests that we get are actually from both medical and behavioral health systems that are needing more. Sometimes it's as basic as those names and pronoun stuff, right? And sometimes it's much more complex and nuanced. But if you have questions about the trans and queer training program, you're interested in that, please feel free to email me. My email will be on in the next slide, but also you can just email me at TQT, so that's trans and queer training, tqt@sou.edu, and we can chat more about the possibility of bringing trainings to your organization and continuing this sort of educational work. So we want to end with some of the Q&A. We have some great questions in the chat, and I see some of them have been answered and some have not. So let's do that. Kylan, would you read a question that has not yet been answered and share a response?
Yes, and I apologize. I was monitoring more of the Q&A section and not the chat section, so I missed some of these questions here. So sorry about that. So there was a question about looking at Two-Spirit resources, and if we had research or any of the study was with tribal communities within sort of the Jefferson territory. And there was a couple questions sort of relating to that. So, what I'll say is we reached out to various communities through various contacts, including through the Native American Studies program at SOU, and we did not get any response to that. And there's a lot of reasons, which I'm not going to sort of get into right here, but one of the things that we are focusing on in terms of who we interviewed in this area is to really highlight white normativity, right? And also thinking about like white supremacy in this area of Oregon. How is that influencing trans people's experiences in this area? Because we did see with trans folks of color some very unique intersections. Did you want to add anything, Carey, to that piece?
I think I would also add potentially that one of the ways where we found some really interesting information, which is beyond the scope of specifically here today was talking about the land projects that are very central in this area. There's a lot of queer and trans and lesbian and gay and so on and so forth land projects, and there's a lot of trans folks that we talked to who had some sort of connection to those or knew about those. And I think they're very complex, right? Because sometimes they're trying to participate in decolonizing work, but they're also land projects. They're about claiming land that, you know, is often not for people, particularly white trans people or white queer people in these areas. So it was a really interesting part that came out in our research. It wasn't specifically related to healthcare, but was something that we have been, you know, analyzing and thinking more about as we've been going through this. Yeah.
Yeah, and I think I'm glad you brought up the land projects because we did see, so there's an established one here in Jefferson County that was created by white gay men, and that has been here for quite some time. There's been some communities, particularly lesbian communities, where it's kind of fading out in terms of a land project. There's also, or was also, a trans feminine land project community that was is no longer in existence. They did not find the support they needed. And then there's actually, I think it was in Douglas County, a transmasculine person of color who was creating a land project. So again, this sort of complexity of creating spaces in unceded land, and what does that mean? There's also, oh, did you want to say something?
Yes, because we have a lot of Q&A and I want to make sure we get to them. So the land projects are places where queer, trans, lesbian, and or gay communities have basically bought land, and they're kind of like going back to the land, living on the land, often like sort of an off the grid sort of approach. And they're very popular in this area, and they have sometimes very long histories. WPATH stands for the World Professional Association of Transgender Health. It is the leading place globally even to get recommendations specifically around transition-related healthcare. I will also share with you that while, you know, WPATH is the sort of leading place, there are also critiques of it, including the sort of gatekeeping that WPATH still has in some of its policies that it recommends. And so it's not without any critique, but it tends to be one of the better places for getting information. What is the cost of the trainings that I was referring to with the trans and queer training program? Please contact me. There's a certain, it depends on the length of the training. It depends on the amount of preparation for the training. But I will say that I also can potentially reduce and or waive fees as needed for the organization. So I'm happy to do that when an organization doesn't have the funding or doesn't have enough funding to meet my fees. I will also say that compared to a lot of folks, I think offering trainings like this, our rates are very competitive, and it's because I work at a public institution and a public university, so I have the ability to offer those for a nonprofit sort of rate. Someone asked about sort of ethical considerations for our research, and we had a lot of them and a lot of things that we considered, both, you know, being in our area, for instance, like we live here, we live in Ashland, we've lived here for 10 years now or more, so we're kind of a part of this community. We know a lot of trans folks in this area, and so we had, you know, sort of ethical considerations around how we navigate our sort of insider status. I myself am both cisgender and non-binary, so I have thought a lot about what that means. I consider myself non-binary because I do not identify with my gender assigned at birth, but I also consider myself cisgender because I know that I get a lot of cisgender privilege structurally for how I look and how people interact with me. And I know, Kylan, I don't know if you want to say anything briefly about your sort of ethical considerations with your identities and such as well.
Yeah, and I feel a little tech challenged because now I'm seeing all the other questions. So I actually am transmasculine. So I was assigned female at birth, and I transitioned a little bit later in life. So, you know, part of us being able to do this study was my ability to have connections. When I was hired at SOU, they were actually looking for a scholar who did trans studies, which is what I do. And because of that, and of course they publicized it when I got hired, I got a lot of calls from people in the community, especially from parents with trans kids. really wanting those resources. And I noticed in some of the Q&A, is there a collection of resources? And there isn't. There's no organization that's really doing that work. I believe, is it Rogue Action Center or So Healthy is trying
Yeah,
to
I
do it?
volunteer with Rogue Action Center. We've been working on it, but we don't have it. I also volunteer with So Healthy, which is our regional health equity center. And we've been working on it, but we don't have it. Like, we don't have a sort of collection of all the sort of health resources that folks are desperately needing. But it's partly because we don't have the infrastructure to keep that updated.
And I want to add to, I want to go back to one of the questions about indigeneity and our inclusion in terms of tribal nations in the area. So the trans certificate that we are offering, one of the required classes is called Decolonizing Trans, and it's going to be taught by Dr. Brooke Colley this spring, who's in Native American Studies. And that was really important to us, that students take that class in order to really understand a much more diverse perspective of trans studies and what's happening in terms of trans lives.
We are at time, I know, Sarah. So we didn't get to all the Q&A. Feeling a little sad about that, but
Thank you so much. What a really important conversation and fantastic presentation. I'm seeing a lot of kudos to both of you in the chat as well, as in some private chats too. What we can do is send you the questions that come in. And if you wouldn't mind answering them by typing them out, then just got a note that I need to put this down. Is that better? Um, we'll post it along with the video and the slides for the session for today. So I really want to thank you both for this presentation. And put a link in the chat to the evaluation for this session. I'm going to do it one more time to catch folks before they leave. And we have another session coming up on November 18th from 2 to 3 p.m. Where our presenter, Crystal Bowman, is going to present on providing specialized emergency care to the aging population in rural Oregon through geriatric emergency department accreditation. So I'm going to put the link for the registration for that in the chat as well. But do look out for some emails from the Oregon Office of Rural Health about that upcoming session. We will also email you the recording, the link to the recording of this session, along with the answers to the questions that we weren't able to get to. So we'll hang out here for another few minutes so you can put those questions in the Q&A so we can have Carey and Kylan answer them. But thank you, everybody. Have a great afternoon.
We'll type an answer too, but since some people are still here, there's a question about like population size. And unfortunately, we just don't know. But what we do know, like the Oregon Healthy Teen Survey that's done in grade 8 and grade 11, seemed to indicate like, I think it was like, I have to look up the exact number, it was something around 8% of grade 8ers identify as trans, and there was a bunch of different categories. And then I think it went down to about 5.6% of 11th graders identify as trans. And the Williams Institute out of UCLA has done some fantastic research, and they estimate more like 10% of youth identify as trans. So, I think increasingly the younger generation is coming out and it is challenging our sort of gender binding. So we're going to see a lot more folks identifying. And what I'll add too is we had an interesting number of trans people respond to our call for interviewees and then say they just couldn't do it because they were too scared that other people might find out they were trans. Even though we of course guaranteed as much confidentiality as we can. It's really interesting to see how many folks loved being here in Oregon, but did not want people knowing that they were trans at all.
Good points. All right, it looks like our Q&A, well, maybe it's not slowing down. There we go. Okay. There is somebody who would like your emails again. And while you do that, type those into, go ahead and type them into the chat actually instead of the Q&A so everyone can see them. Somebody did mention earlier in the Q&A that There is an Oregon Echo currently ongoing, but there will be another one next year on gender affirming care across the lifespan through Oregon Echo. So as soon as we get more information about that Oregon Echo, we'll make sure that folks get that information because I think it's really important and a deeper dive too into how to address healthcare for trans folks. So fantastic. All right, thanks again, Kylan and Carey. Really appreciate it. We'll close out this session. I'm going to stop the recording.
Great.
Thank you.